How many people do you think are on antidepressant tablets and that shouldn't be?
An SSRI is a selective serotonin reuptake inhibitor.
And of course, changing brain chemistry in itself also might have other harmful consequences in the long term. That might be what these drugs do is they inhibit the protein.
In the past few months, the UK was almost literally taken by storm by a paper that was published in Molecular Psychiatry by Joanna Moncrieff's team, exploring the involvement of serotonin in depression, and finding that despite a widely known version of the monoamine hypothesis of depression, which was the serotonin hypothesis of depression, there is really little evidence for the direct involvement of serotonin in major depression. That is to say that depressed patients don't seem to have abnormally low level of synaptic serotonin. Now, despite the fact that the paper only explored the involvement of serotonin in depression and did not discuss the data supporting the efficacy of antidepressant treatment, the paper was widely presented in the British mainstream media as a death blow for antidepressants, despite not really being warranted to do so. Unfortunately, the media frenzy that started got quite a number of patients caught in the crossfire, in that you had psychiatrists, like Wendy Byrne, who's quite well known on Twitter, saying patients had contacted her asking if they'd had, quote-unquote, imagined their symptom alleviation from antidepressants, and other people asking if this study now means they should stop their medication, which is quite problematic, obviously. As far as I know, you are still working as a prescribing clinician at Oxford. Has this happened to you in the aftermath of the media storm over the paper? I'm talking about patients asking if they should go off treatment due to the media frenzy.
So, yes, I read the paper and I'm aware of the debate on media, social media, and also in some of the scientific journals. Starting from the last question, no, I haven't received any questions like this from the patients I see in my clinic, but I can understand why people may feel this uncomfortable situation of receiving information which is, of course, a bit simplistic, because I don't think that nowadays psychiatrists, mental health professionals think that there's one type of depression. It's very difficult to well, I don't think it's the reality that there's one single expression of the depressive disorder. Each patient is different, and rejecting the hypothesis that neurotransmitters are involved in depression, I think, again, this is simplistic and wrong. What is definitely correct, but it's not new information, is that the so-called chemical imbalance is not true, of course, and it's a wrong way to express what may be the mechanism of action of these neurotransmitters. So definitely I agree that this is not the right interpretation of the biology behind the effects of drugs on the brain, but I would not reject altogether the fact that actually neurotransmitters have an effect in what we see as the consequences, therapeutic consequences, but also the side effects of these medications.
Now, maybe let's actually briefly go over why this study can't really make any claims on antidepressant efficacy, why it was so easy to draw that conclusion, and why it's an important distinction to make.
Yeah, as you say, the study, this study by Joanna Moncrieff and colleagues wanted to look at the effect of this medication in the synapses, but of course to test the clinical effects of any intervention, whether it's pharmacological or psychological or like a device or whatever it is. We have to test this intervention in clinical trials, and of course it's not a modification in the brain or in another organ in a human being that automatically translates into something which is demonstration of effect or no effect.
Also, I got to ask, because the paper's rationale, or at least secondary rationale, was supposedly correcting a myth that's been long held by the general public and clinicians alike, that depression is the result of abnormally low levels of serotonin in the brain, and that antidepressants correct them, thereby reducing depressive symptoms. But the only study this paper cites to support this supposed belief amongst clinicians is a small study run amongst British general practitioners in 2019. I do have to say that no Romanian psychiatrist I know subscribes to this simplistic view, much less delivers it to their patients. Even if you look at all the Romanian treatment protocols from the 2000s, they don't endorse the serotonin imbalance theory as an actual explanation for depression. What's it like in the UK? Do you know of any psychiatrists who actually endorse the serotonin hypothesis of depression?
No, personally, no, I don't.
There's also a widespread claim that's been taken up again these days about the way in which antidepressants work, and that is that they are claiming to blunt affective response across the board, meaning patients will get less angry, less enthusiastic, less agitated, and incidentally less sad and depressed. And this is how antidepressants are claimed to work. The implication being that this is basically cheating on the part of psychiatry when it claims it's treating depression, but it's actually, quote unquote, treating the entire affective spectrum. And this is why you are seeing the response you are when you prescribe antidepressants. I know this is something that's sometimes been reported by some patients, but not all of them. Is there any good data to back this claim that antidepressants dampen emotional responses altogether?
So we have data showing that antidepressants may have an effect on people with depression. And as I said before, depression is a very heterogeneous disorder. So in some people, what prevails is the most predominant features are low mood. In other people are anhedonia or insomnia, lack of appetite, the suicidal thoughts, all these dimensions. So one of the effects of the antidepressant, a therapeutic effect, can be not directly or specifically on the mood, but on the other dimensions of the disorder. But I have to say, and that's not only the evidence, but also my clinical experience, that for some people, antidepressants may somehow flat the mood. So people are feeling better, but they don't react. And this is the expression that many people use talking about the so-called negative effects of this medication. But I think everything has to be put into context. I don't believe in average effect of treatments. I think what we really need to do is to move to the individualized or personalized treatments, which means that also in terms of how we measure the effect of an intervention, positive and negative, has to be tailored to the individual.
I see. Now, back in 2009, you were the lead author of a landmark paper in The Lancet, which was the first network meta-analysis in psychiatry that explored 12 new generation antidepressants and their comparative efficacy. I know that by then you had just finished your residency in psychiatry in Verona and were frustrated by prescribing protocols that were conflicting and confusing and the messy interpretation of the data that was already out there. What was it like doing a psychiatric residency in Verona in the 2000s? Do you remember some of these conflicting protocols that were being used back then?
Yeah, Yes, I remember when I was training, because in Verona we have a community mental health team. So we look after patients across all the settings, from the community to the inpatient wards. I remember we had many people suffering from depression. For instance, the situation here in the UK is completely different, where people with depression are mainly seen by GPs rather than psychiatrists. But I was finishing my residency, and I remember when we decide with the patient that an antidepressant was the best treatment to to prescribe, the decision about which treatment to give to patients was clearly biased by the opinion of the senior member of my clinical team or the information about the latest antidepressant on the market, because they presumably didn't have some adverse events, but they were equally effective. So I remember discussing with Corrado Barbui, my mentor in Verona at that time, do we have any evidence-based hierarchy to see whether there's one antidepressant better than another? And so the question was, which is, if any, the best antidepressant to prescribe to our patient as a first-line treatment for depression? For this reason, when we designed the study, we look only at head-to-head studies. So we did not include placebo, because the clinical scenario I had in mind was, I'm with the patient, we've decided to start an antidepressant, what is, if any, the best one? So it was not about whether antidepressants work, but it was more about what is the best treatment to give to my patient. And again, I was part of the Cochrane collaboration at that time, and Corrado and I met with Giorgia Salanti, who at that time was moving from Cambridge to Munich and then back to Greece, where she's coming from. And now she's in Bern, at the University of Bern. And Georgia was pivotal in developing this new technique, which is called now network meta-analysis. At that time, it was called multiple treatments meta-analysis, where you can compare directly, but also indirectly, all the treatments that are included in a sort of network, in a series of comparisons between active interventions. So it's true, this is the first fully, properly conducted network meta-analysis in mental health, but I had the inspiration from previous network meta-analysis published, for instance, about diabetes, treatment for diabetes, or hypertension, or HIV.
Right. And so if we explore the results, this is the kind of graphical representation you usually get in a network meta-analysis, where you have all these direct and, more importantly, indirect comparisons. So, for example, you have fluoxetine and sertraline that were compared in a large number of trials, hence the width of the line between them. And you also have fluoxetine and paroxetine that were compared in a similarly large number of trials, and you get a line that's approximately the same width. So the lines are head-to-head clinical trials exploring the comparative efficacy of these drugs on depression. There is a point to be made here, though. As you said, this was very early on, when this method wasn't even called network meta-analysis, but rather multiple treatments meta-analysis. So this was a pioneering study that you ran with a very strong interdisciplinary team of researchers. You had clinicians, you had biostatisticians, but as the method became more and more popular, as it had in the following decade, network meta-analyses started popping up everywhere in the mental health literature, from psychiatry to clinical psychology. And as it usually happens, when a certain method starts snowballing in a field, the quality usually drops, sometimes dramatically. And if you don't have a good eye for methods and stats, it becomes very difficult to discern between studies. Since you've been involved in many network meta-analyses since 2009, and you've built this strong team that you've collaborated with since then, what are some of the pitfalls of this method that readers should really be aware of before even considering their results?
Yeah, the most important thing is that the quality of the information is of paramount importance, even more in a network meta-analysis than in a pairwise or standard meta-analysis, because you are comparing, as you see in this slide, many interventions at the same time. And the added value of network meta-analysis is what we call you fill the gaps. So in this slide, if you look at the top right, reboxetine and mirtazapine, there's no line between the two. Each line represents the studies, comparing the trials, comparing two interventions, and the width of the line is proportional to the number of studies. So there are many studies comparing sertraline and fluoxetine, as you said, fewer studies comparing sertraline with reboxetine, but there's no studies at all comparing reboxetine with mirtazapine. So in a standard meta-analysis, the answer is no data. While in a network meta-analysis, you can compare indirectly reboxetine and mirtazapine via a common comparator like fluoxetine, for instance, because we have studies reboxetine, fluoxetine, we have studies fluoxetine, mirtazapine, so we can calculate the indirect evidence reboxetine, mirtazapine. So we fill the gap, but also we can use the network to check what we call the consistency of the information. Look, for instance, sertraline, fluoxetine, it's highlighted. We have a lot of studies sertraline, fluoxetine, but so we have a direct estimate of this effect. But at the same time, we have studies sertraline, venlafaxine on the bottom right, and venlafaxine, fluoxetine. So for sertraline, fluoxetine, we can also calculate the indirect evidence via venlafaxine. And having the direct evidence, the solid line sertraline, fluoxetine, and indirect evidence via venlafaxine, we can test whether the treatments are, or the two effects are consistent. So they are in agreement. They show more or less the same conclusions. For all these reasons, the consistency and the other important assumption, which is called transitivity, network meta-analyses are more complicated, but this is also one of the potential limitations of the meta-analysis. Transitivity means that the information can flow across the whole network, going from one treatment to the other, which means that the population of patients included in the study, the types of intervention should be similar. There's no point in having studies with a population of patients with depression, mild depression, combined with patients with treatment-resistant depression, because these are different population of patients. Or in terms of the intervention, there's no point in combining oral formulation with IV formulation, because we know, for instance, that the effect for depression may be completely different. So all this has to be taken into account. And unfortunately, nowadays, network meta-analyses are very popular. So many researchers don't give enough attention to these fundamental assumptions, which can undermine the validity of a network meta-analysis if they are not properly done.
So, and if they are not properly done, these consistency coefficients and this kind of data will show up.
Yeah, sorry to interrupt. Yeah, that's interesting, because consistency is something that we can measure with statistical tools, but the transitivity can't. Of course, it is indirectly related to consistency, but it's a different thing. And this is why every time I talk about network meta-analysis, I emphasize the importance of having a multidisciplinary team doing a network meta-analysis, because the transitivity should be addressed from a clinical point of view, from a methodological point of view. We always now have the members of the public being part of our teams, because it's important to combine different views and have a very coherent message at the end.
Right. And I think this raises an important point, that in clinical practice, you often don't get access to an interdisciplinary team where you can collaborate with statisticians who can actually help translate and implement the results that you are reading in the literature, which is a recurring issue with translational medicine, in that, as you said, in this 2017 review on network meta-analyses, clinicians rarely have the time to critically appraise the literature they are reading. But more importantly, they unfortunately rarely have the statistical and the methodological background to really evaluate the results they are looking at. And I think this is something that's rarely explored unless you really go through journal issue by issue. That is, the post-publication conversation over a certain paper, where you can usually come across sophisticated methodological points over the data processing and interpretation in a certain paper. But more often than not, these discussions are buried in short letters that get published in subsequent issues of the journal, and it's not that easy to keep track of them, which is why I think it's somewhat important we explore some of these discussions. This was a letter that was published after your 2009 meta-analysis came out, a couple of issues down the line, and it was Gerald Gardlener and his team who had also published a similar meta-analysis the year before and had come to different results. It's important to say that your 2009 meta-analysis did actually find that escitalopram and sertraline had the best possible balance between efficacy and acceptability, and that they were probably the best choices to start a treatment for depression. Incidentally, these are both selective serotonin reuptake inhibitors, meaning they work by raising the synaptic level of serotonin. Now, Gardlener and his team had conducted a similar meta-analysis the year before. It was a paper that has been published in the Annals of Internal Medicine that had looked at pretty much the same 12 second-generation antidepressants you had explored in your meta-analysis, except for nefazodone and trazodone, which you had replaced with milnacipram and reboxetine. But they concluded that there wasn't sufficient evidence to warrant the choice of any single second-generation antidepressant over another. And one difference between your methods was that they used relative risk to convey their results, whereas you had used odds ratios. And their point was that this was misleading in that readers were likely to overestimate the clinical importance of your results, as they had been expressed through odds ratios. Why do you think that is?
I think Gerhard Gardlener has a point if he says that odds ratios are not intuitive. So as clinicians, and I think as humans, when we look at relative differences, we tend to think in terms of relative risks, probabilities, rather than odds ratios, and which is less intuitive. Odds ratio is a ratio of odds, are used when usually by people who bet, because it's in odds is the number of events out of the number of non-events, while the risk is the number of events out of the total number of possibilities. So the example I give usually is a dice. So if you throw a dice, and usually dice have 6 sides, the probability of having the side with number 2 is 1 out of 6, and this is the risk. But the odds is 1 out of 5. So for very rare events, risks and odds are very similar. If you think of a dice with 100 sides, the probability of having side 2 in terms of risk is 1 out of 100. In terms of odds is 1 out of 99. So it's very, very similar. But for frequent event, of course, odds and risks can be very different. So this is why it's not automatically to translate risks into odds and into probabilities. Having said this, odds have very good statistical properties. So this is why in the protocol we define the primary outcome as odds. And the second point is more philosophical, if you want, because as I said, odds are used by people who bet, who make a betting about the horse or what is the results of a football match or whatever it is. So you really put your money on one option as opposed to another. And because we had 12 treatments at that time and we had to decide which one, if any, was the best, I think odds were, and odds ratios consequently, were the best way to analyze the data.
I think there is a couple of things to be pointed out here. One is that it was unlikely that some clinical results were simply an artifact of using odds ratios. such as the fact that reboxetine and duloxetine seemed to do poorly on both efficacy and acceptability, whereas sertraline and escitalopram did better on both of those criteria, with only 50% of sertraline trial data being provided by Pfizer, the manufacturer, which I think is quite important, since the other data was provided by competing companies with sertraline as a comparator in head-to-head trials, though there was significantly less risk of bias. Secondly, you came back to ecological validity, that is, clinical applicability. There had been a suggestion about matching specific adverse effect profiles to specific patients, which was certainly interesting from a clinical point of view, but would have been far too complex to implement in actual clinical practice, and this was the point that you made in your response, that you were concerned with clinical applicability for clinicians and patients alike, who had faced a lot of uncertainty making clinical decisions, with the other point being that the consequence of not exploring the differences amongst drugs in terms of efficacy and acceptability was that this set a low threshold for introducing new agents to be marketed as being similar to what was already out on the market, rather than having clear advantages in terms of efficacy and acceptability. However, there were a couple of points that were raised by critics, one of which was John Ioannidis. You already explained the decision process behind not including placebo studies in the 2009 meta-analyses, and it was a good point, since you don't prescribe placebo in the clinic, but rather choose from a limited number of active substances. Ioannidis pointed out that this was no trivial issue and that it could significantly affect your results, since the data you had excluded was considerable. The second line of criticism was from Eric Turner. It was over publication bias, and it echoed Ioannidis' concern in this area, which was that publication bias was already known to be considerable. In 2008, 1 year before, Eric Turner had just published a landmark paper exploring publication bias in antidepressant trials. This was really a crucial article. It was co-authored by Robert Rosenthal, who's pretty much the godfather of what we nowadays call publication bias. He actually had coined the term file drawer problem in the late 70s. And so what this data had shown was that there was significant publication bias in the antidepressant literature, and that it impacted the presumed efficacy of antidepressant treatment quite a lot. What was the process of controlling for publication bias back then in the 2009 meta-analysis?
Yeah, so we look at the unpublished data, which is what Eric showed in that paper. And I totally agree with both John Ioannidis and Eric Turner that these are important things to take into account. Of course, we did our best to collect as much as possible unpublished information, but it's never enough, because we know that pharmaceutical companies tend not to make available studies that don't show an effect, a positive effect of the medication they are producing. For this reason, we look not only at the company website, but also we look at the website of regulatory agencies. We looked at the clinical trials registries, where somehow the researchers should report some results and information. So it's a combined effort, but it's in progress, because if we look back in 2009, what we have now in terms of availability of unpublished data, the situation now is much better. We have better, more balanced or less biased information about the effect of the medication. And to be honest, I've worked a lot also in the non-pharmacological literature, identifying the studies unpublished for psychological treatments is even more challenging. And again, industry, they have a bias in terms of producing or licensing a drug that works. But in psychotherapy, of course, the investigators have the intellectual bias because they believe in the intervention they are promoting. So it's always important to look at unpublished data everywhere. Going back to John Ioannidis' comments about the placebo, I mean, as you said, it was a clinical judgment at the beginning, so we did not include placebo. It was by choice. But in the 2018 update of the network meta-analysis on antidepressants, not only we included placebo in the network, but we also have John and Eric as co-authors of the paper.
Which takes me right to my next question, because as we move almost 1 decade later, in 2018, when you updated this work with another landmark paper that was published in The Lancet as well, this time you explored 21 antidepressant drugs, which was pretty much every medication still available on the market for treating depression. And just before we go into the paper, it's somewhat remarkable that John Ioannidis and Eric Turner, who stood out with their criticism of your 2009 paper, had been recruited as co-authors. I do have to say that it's quite the rare occasion to witness such impartiality in terms of taking criticism seriously. First of all, how did you get them on board?
Well, first of all, I'm happy to receive criticism, and I mean, it's part of our job. We need to challenge the science we produce. So it's absolutely fine to receive this kind of comments, also because they're very clever people. So these type of comments are always welcome. But the reason why I wanted John and Eric on board was exactly to overcome the controversy, the ideological controversy around antidepressants. So I'm a clinician. I want to give the best treatment to my patients. I have people in my clinic who want antidepressants. They don't want talking therapies. They don't want anything else. So I feel I have the moral duty to understand whether these drugs are effective. And if they are effective, again, is there any agent which is better than others? So for this 2018 paper, I expanded the question, not only whether there's one antidepressant better than others, but also whether antidepressants are potentially an effective tool to treat depression. So what I did was I drafted the protocol, and before we started the search and everything else, I contacted John and Eric and said, my ambition now is to have a study design and network meta-analysis answering these two questions. Before we move to any results, anything material, are you happy to be on board and undersign basically this project, be part of the team, because you think that this is the best methodology to answer the question? They both said yes, and this is why they are on board.
I see. Also, this is something I do have to ask. It might not be readily answerable, but how much did this study end up costing? Because I know it was a massive undertaking. It took you guys over 6 years of work to actually get this done.
Yeah, that's, how can I say, old school psychiatry, because we didn't have a specific funding for this. It was based on a group of people, especially myself, Toshi Furukawa, Georgia Salanti, Stefan Leucht, and John Geddes. And we've been working together for so many years, and really wanted to do a state-of-the-art network meta-analysis, but also answering a very important clinical question globally. And probably this is why this paper also was published in The Lancet, because we included data about antidepressants in the WHO list of essential medicine. So we wanted to inform a policy about antidepressant treatment worldwide. And we relied only on the goodwill of the people who were involved. Just to give an example, the Japanese team, they recruited 10 people working for months and months and years, extracting data, selecting papers, and the reward was the name of the people on the paper, but no money involved.
I see.
The reason why it's the NIHR, if you can see the previous slide or the next one, I don't know, when the funding is mentioned, is because when I was here in Oxford, my salary is funded by the National Institute for Health Research, but it was not a specific funding for this project. It was more to allow my time to be dedicated to this project. And the same for Japan, for Toshi Furukawa. But it was not a grant.
Yeah. The amount of work the data extraction teams put in becomes quite obvious when you consider how large this meta-analysis was. It included 522 trials and over 116,000 participants. By far the largest meta-analysis ever done on antidepressants. And you made a number of significant changes from the 2009 study, like including many continuous outcomes, as opposed to just dichotomous outcomes in the 2009 meta-analysis. What was the decision-making process for choosing these outcomes?
Yeah, it was, again, to answer the criticism. We received a lot of letters also about the issue that dichotomous outcomes, or response, non-response, may inflate the effect of antidepressants. So this is why we decided to keep response rate and dropout rate at 8 weeks as the primary outcome, because it was the same outcome of 2009. So we wanted to be consistent with the update, but also because as clinicians, and I have to say also the feedback I have from patients, when we present the evidence, the question is, does it work or not? Am I going to respond or not? So this is clinically very, very meaningful and sound. However, as secondary outcomes, we thought it was important to include other outcomes. One is the change in symptoms, or the endpoint score of the depressive symptoms. Another secondary outcome was remission rate, because response is defined as a 50% reduction of your score from baseline to endpoint. Remission is actually having a score below a certain threshold, which means you don't have symptoms of depression. And the third secondary outcome was dropout due to adverse events, because the primary outcome is all-cause dropouts, but it's important to understand whether some antidepressants cause more side effects, and that leads to dropout, which is a sort of proxy for tolerability.
Now, with regard to publication bias, as Eric Turner had shown in 2009, when you had published your first meta-analysis, we knew that publication bias was quite considerable. How was the process of exploring publication bias this time? What had changed?
Well, as I said, the approach was very similar. The difference is that more recently we have more information available, because more companies have to report the data in registries. In 2009, GSK had to do this because by law, they were forced to do this after the paroxetine problems, but not other drug companies, while now basically all companies have the data. The second thing, available in the registries. The second thing is possibly the big difference between 2009 and 2018 was, having published the 2009 review, we had some good reputation in the field about doing this kind of studies. So I approached personally all the authors of the studies and also the companies, asking for additional information with the technique that I always use, which is name and blame. Because if we report in the papers the companies that helped providing additional information, the moment you don't name a company or authors or whatever they are, we know that we approach everybody, so it means that they didn't contribute with data. But it's an ongoing process. We will never be sure that we have everything, and this is one of the big limitations of the project. Things are improving, but are far from being perfect.
It's then interesting to look at this 2022 update you just put out. This is basically an update of Eric Turner's 2008 landmark paper on publication bias in antidepressant trials that concluded that while this is still certainly an issue that affects researchers and therefore decision makers and stakeholders, reporting bias does seem to be diminishing for newer antidepressants, which I guess you could call a silver lining.
So the process is the same. We try to find the information in the same places, same sources of information. But this study led by Eric, published in PLOS Medicine, showed that what was true in 2008 when he published his landmark paper in the New England Journal of Medicine, now things have changed. So the most recently marketed antidepressants tend to report more transparently the information in the regulatory website or company website. So the unpublished data are more easily available, and there's less risk of publication bias, as you can see in this graph.
Yeah. Now, coming back to the 2018 meta-analysis, there is quite a lot of studies that you included that had very low quality of evidence, some of which are highlighted here in red. But you can see there's others, all the ones that have a double cross next to them. The ones highlighted in green are examples of studies that have moderate quality of evidence, and we've highlighted them in green because there's no studies having a quality of evidence that's better than moderate. So what exactly did you code for in quality of evidence, and why were you as tough as you were assessing it?
So these measures of, let's say, quality is not just the quality of the evidence of the individual studies, is not just the risk of bias that, as we call it, is a more complex measure combining also how precise is the estimate, all this, how informative is the estimate or the information retrieved. So it's what we do with a system called Cinema, which is has been developed by Giorgia Salanti and her team in Bern, which is a way to assess the confidence in the estimates from network meta-analysis. So this is what the acronym is, Cinema, and is how reliable is the information. It's slightly more complicated than simply what is the quality. Second, it's true, if you take all these domains into account, we don't have high quality information. And as a clinician, again, my problem is always the same. So it's important to describe the available information, but as clinician, I need to take decisions with my patients. So even if it's not ideal, even if it's sometimes low or very low, it may be that this is the best available information. I'm not saying it's enough because we need to do better, but when I discuss with my patients what to do, I present this table, I tell them what are the risks in taking one intervention as opposed to another one, and we have a transparent and shared decision-making process, taking into account also how robust is the evidence or the quality of the evidence. But I would not throw away the baby with the bathwater, which is the risk of dismissing everything only because it's bad quality. And if you look at what happens in medicine, it's the same. I mean, I don't know why mental health is so ideological, but in other fields of medicine, from cardiology to cancer to hematology to respiratory disorders, there's a lot of evidence with low quality, but this is part of the decision-making process. So I strongly believe that we need to be transparent, we need to be aware, but we should not dismiss something only because it's low quality, because it may be for this specific person in this specific situation the best option.
So we are looking at the list of antidepressants you explored. What I've highlighted here in orange are SSRIs, so drugs that work specifically by inhibiting the uptake of synaptic serotonin. I was wondering if you had by any chance pulled an effect size specifically for these drugs, since we are mostly discussing serotonin and its involvement in depression.
No, we, as per protocol, we wanted to look at this information by drug. So we didn't have any grouping in terms of drug classes.
The reason I'm asking about effect sizes is that many times readers, and especially readers in some particular subfields, will go looking for effect sizes more than anything else when evaluating the importance or the clinical relevance of a certain intervention, whether it's organizational, educational, clinical, what have you. Maybe you could clarify what odds ratios are, how they are used, and how they are different from effect sizes.
So odds ratios or risk ratios are used for dichotomous outcomes. So response, non-response, like in this case, it was efficacy as response rate. Effect sizes are for continuous outcomes, like standardized mean differences or mean differences. Of course, you can then calculate an odds ratio from an effect size. These are mathematical calculation that you can do, but these are in principle different things. So we reported for the analysis of the secondary outcome of the continuous outcome change in symptoms or endpoint scores, we report the effect size.
Right. And it's then important to note that the SMD you pulled was 0.3, but this was an average of all the effect sizes for all the antidepressants included. And so there is drugs that certainly produce SMDs that were higher than 0.3. Also, going back to clinical relevance, it's important to note that these results are averages of individual scores, meaning that certain patients will experience improvement that are significantly higher than the average, while others will do poorly. So with regard to clinical applicability, these results could be highly dependent on subgroup analyses, out of which I'll just focus on 2 or 3. The first, and I think the one that most, if not all readers were eager to look at, is commercial interests, namely funding by industry, which means you explored the differences in results between studies which had been funded by pharmaceutical companies compared to independent investigators, and found no differences in terms of response or dropout rates. But importantly, you mentioned that non-industry funded trials were actually few, and many trials did not report or disclose funding. I was wondering if you then had enough statistical power for these comparisons.
No, we didn't have enough statistical power because, as you just said, the great majority of studies were funded, so we couldn't really explore properly this issue. In terms of the results, it's true that in the end, the funding by industry was not associated with material differences in terms of efficacy and dropouts, which is the acceptability. But it is true that we found some significant association with the novelty effect, which is when we look at comparison, when the same drug was the new one, or so the intervention drug, or the old one, the comparator, the effects, so the efficacy of this medication, the same medication was different, which is a bit strange because you expect the same drug to be always with the same efficacy. And this is where the network meta-analysis helps, because if you have a network of all treatments, in the end, this novelty effect is somehow diluted across the network because the same drug is with some comparisons new, with some other comparisons the reference old, which means that there's a sort of balance between the two.
I wonder how much has changed since 2018. Are there more non-industry funded trials out there?
Not really. A bit more, especially for long-term treatments, so maintenance treatments. There's a recent study, the Antler study, published in the New England Journal of Medicine about maintenance treatment of antidepressants, or there's the PANDA trial about sertraline, which is an independent study published by, supported by the National Institute for Health Research in the UK. So we have very good examples of very good studies, but numerically, the number of industry-sponsored studies is much, much higher.
The other subgroup analysis I was looking at was dosing schedule. Now, going back to clinical relevance, we know that in day-to-day practice, there's a non-trivial number of patients who need to switch medication after being put on first-line treatment, whatever that is, due to adverse effects that are either uncomfortable or downright intolerable. Dosing schedule, as far as I can tell, does not include this type of data.
Yeah, we did not include patient who switched from one medication to the other. The dosing schedule here refers to flexible dose versus fixed dose, which means that in some studies, let's say you start with sertraline 50 milligrams for the 8 weeks duration of the study, and you don't change the dose. But other studies about sertraline, you can have a range between 50 and 100 or 200, whatever it is. So you can change the dose. And what happens usually is that after 1 week, if patients do not respond, they increase the dose from 50 to 100, for instance. But then if you increase the dose, you expect, in theory, that the treatment is more efficacious, but you have a higher risk of adverse events. So the problem is a flexible dose regimen is somehow personalized, so better tailored to the needs of the patients, while a fixed dose is one dose for everybody, so you may disfavor the drug. And this is why we predefine in the protocol a subgroup analysis looking at for the same drug with or without the fixed dose or the flexible dose studies.
There is a final point that I wanted to make about subgroup analyses and clinical practice. There is quite a lot of data showing that response to depression treatments is moderated by social support and social stressors, which are obviously quite heterogeneous amongst participants in antidepressant trials. Is that a moderating variable that's ever measured and included as a covariate?
Yeah, there's a good point, because with one of the big limitations of this project is the available information reported in the papers, and this information is seldom reported and very, very heterogeneous in terms of what is written in the papers. For this reason, what we are trying to do since the 2018 Lancet paper is trying to move from averages, so from the summary report of the mean effect, to individual patient data. We managed to collect individual patient data from 140 randomized controlled trials from this Lancet meta-analysis, and we are now analyzing all this information. We have some more data about the social determinants and other outcomes that usually are not reported, but it's still a long way.
Finally, going back to the psychiatric residents and clinicians whom you started out doing this work for, how would you summarize the 2018 results when discussing clinical significance?
My take-home message is that antidepressants may work for depression because all antidepressants showed better efficacy profiles, which means that at least for some patients, antidepressants can work, but the big challenge is to understand what works for whom. The problem is that in this meta-analysis, we did not analyze the specific side effects, which is an important component. So it's only part of the full picture. We can't base our judgment only on this data. But if you look at the number of people who drop out from the study after 8 weeks, there's no big difference antidepressant with placebo. So in the end, it's safe to assume that they are somehow an acceptable treatment for the acute phase of the illness. The big questions that remain unanswered are how long we should continue the treatment, and also what is the best treatment for each individual, and of course, what is the cost effectiveness of this intervention, which are unanswered. But I think we should, this is why also in many interviews afterward, I said, now we know that antidepressants are better than placebo, so we should try to understand what happens in other difficult conditions, less studied, like treatment-resistant depression, for instance, or psychological treatments, for instance. But when I say we know that antidepressants are better than placebo, it means they are better on average. There are still people who do not respond to antidepressants. There are still people who have severe adverse events from antidepressants. So antidepressants are not a one-size-fits-all approach for everybody with depression. On the contrary, they should be used only when appropriate.
Now, this meta-analysis obviously got even more publicity than the 2009 one, and for good reason. It was a way larger study that had much more sophisticated data analysis. And what you had noticed was that you hit the same wall many researchers exploring psychiatric treatments hit, which was people took your results to confirm their pre-existing beliefs about treatment efficacy. This is the reference list from your letter to the Lancet, where just 1 month apart, two major outlets, the New York Times and the Guardian, discuss your paper and come to opposing conclusions. That is, either antidepressants are effective or antidepressants have modest effects. What was the controversy like for you back then?
Yeah. I mean, this is how people interpret the results. And these are two examples from newspapers that can fuel controversy or try to hit the headlines. So I think that the big problem for me was that people tended to take one position or the other, like they work or they don't work. As I said, it's a bit more nuanced, the answer. I think antidepressants are a tool, an effective tool that can be used in some circumstances when the patient is happy to have the antidepressant, where they are indicated and all the things we just discussed before, but should not be an easy fixed solution for everybody with depression, because we know that there are thresholds, and the more severe the symptoms, the more likely the patient is to respond. It's not just giving the antidepressant, it's also seeing the patients, having a 360-degree care for our patients, which is not only medical, it's the biopsychosocial approach, I think, is still the best way to treat people with these problems. But the risk is, if you say that antidepressants don't work, full stop, that you leave untreated a lot of people, and untreated depression is a very terrible disease, because it not only can lead to suicidality, but also it's a huge suffering for the individual and the society, with huge burden for everybody.
Professor Cipriani, thank you. It's been a pleasure talking to you. Obviously, integrated care is always the best option when it's available. And as you've said, the issues that affect antidepressant research are always there for psychotherapy research. Everyone should be aware of the work that's been carried out in the past decade by Professor Pim Kuiper's team in Amsterdam. And what they've repeatedly shown is that psychotherapy research, including for depression, has many of the same issues that are present in antidepressant research. Many negative studies are not published, and as you've said, they're much harder to get a hold when you are doing a meta-analysis, because psychotherapy research isn't regulated, and therefore unpublished data is much harder to find. Effect sizes drop when you correct for risk of bias and only include well-conducted studies. And most meta-analyses, included some you've also worked on with Pim Kuiper's team, show that there really isn't that much of a difference between antidepressants and psychotherapy when it comes to treating depression. And I think a good conclusion to our discussion comes out of the 2022 meta-analysis published a few months ago by Falk, Lichsering, and John Ioannidis in World Psychiatry that importantly concluded, quote, "In summary, a systematic reassessment of recent evidence across multiple meta-analyses on key mental disorders provided an overarching picture of limited additional gain for both psychotherapies and pharmacotherapies over placebo or therapy as usual. A ceiling seems to have been reached with responses rates less or equal 50% and most SMDs not exceeding 0.3.4. After more than a half a century of research, thousands of RCTs and millions of invested funds, the trillion-dollar brain drain associated with mental disorders is presently not sufficiently addressed by the available treatments. This should not be seen as a nihilistic or dismissive conclusion, since, undoubtedly, some patients do benefit from the available treatments. However, realistically, facing the situation is a prerequisite for improvement. Pretending that everything is fine will not move the field forward, nor will conforming and producing more similar findings." End of quote. Bleak as it may be, mental health treatments are far from what they need to be and we know that. Using studies such as the one published by Moncrieff, which has nothing to do with antidepressants, to claim that antidepressant medication is not effective for depression is not a move that helps anybody, much less the patients who need mental health care. Thank you, Professor Cipriani. It has been an honor.